All right, want to welcome everyone to DCRI Research Conference. It's a special privilege to introduce Ashish K. We were actually residents together at UCSF and have sort of been keeping track of each other. Still a little bit behind. He has 9 New England Journal articles. I have 0. But I do have 14 American Heart Journals articles, and he has 1. And then his rebuttal is always about JAMA, but as you'll see later today, he's catching up with a nice commentary about HIT. So he's an associate professor of health policy and management at the Department of Health Policy and Management at the Harvard School of Public Health. He's also an associate professor of medicine at Harvard Medical School, as well as an associate physician at Boston's Brigham and Women's Hospital and the VA Boston healthcare system. So over the last several years, he's really served for the VA in terms of being a special advisor for quality and safety there. And he's also a practicing internist focusing on inpatient hospital care. His research has focused on quality of care in terms of healthcare systems and effectiveness, health information technology as a tool to reduce disparities and disparities in care, as well as hospital governance. So here today is going to talk about the use of health IT in the US. Apparently has all the answers in terms of both cost and quality. I look very much to your talk here.
Great, thank you, Adrian. Everybody can hear me okay? Great. So what I'm hoping is that in the next 55 minutes, I assume we go till 1 o'clock, is that we can really have a discussion about health IT, and I'm going to try to frame the conversation by sharing a couple of big picture slides as a contextualizing thing of why we're here. And I do this because it's very easy when you look at the IT discussions that go on in Washington and other places for people to get incredibly focused on the technology part of this, that we're trying to somehow put in electronic health records. And my sort of reminder is we're not trying to put in electronic health records, we're trying to make the healthcare system work better, right? We're trying to make quality better, cost better. And so as the kind of underlying principle, let me see if I can just spend a few minutes. And as we do this, let me actually just one more sort of rule of the road. I would love it, and I mean this, I would love it if people would interrupt, if people would ask questions. If I say something that you completely disagree with, I would love it if you pushed back. And hopefully there's a microphone somewhere in the room so that your questions and taunts and whatever else you have for me gets recorded and broadcast. Okay? So, but I'm completely serious. The more that this is a discussion, the better it'll be, I think, for all of us. All right. So here's what I'm going to try to do for the next 45, 50 minutes. Talk a little bit about, the big picture, high cost, variable quality. Try to give you a little sense of what does this have to do with HIT? Why am I bringing this up? Then I'm going to get into some data, some of the stuff that we've done trying to actually look at what do I mean by health IT? What do I mean by electronic health records? Where is the country in this? And then think about the national policy scene going forward in this area. Okay? So again, I'm going to ask you to indulge me for 2 slides worth of stuff that you all know. But just as a kind of context setting, $2.5 trillion, right, in 2009, 17% of GDP. That comes out to, by the way, about $8,000 for every man, woman, and child in America. And as a way to contextualize how much money that is, a full-time minimum wage worker makes about $12,600. So if you think about how much healthcare costs about $8,000. And if you work full-time minimum wage, you earn about $12.5 grand. Healthcare for the average person is extremely expensive. Now, most people don't have to pay that out of pocket, but it is extremely expensive. And the numbers for the best projections we have just came out of some actuaries at Health and Human Services suggesting that we're going to be at about $4.6 trillion in 9 years. And a couple of interesting things about this. So, whenever you talk about healthcare costs, people ask the question, how much of a problem is this really? It sounds like big numbers, but is it a problem to spend a lot of money on healthcare? And the answer is, it's not fundamentally problematic to spend money on healthcare. You're going to spend money somewhere. Healthcare is a good place to spend it. But there are some specific issues. So one is, if you probably know this, but in the last 10 years, wages for American workers has been pretty much flat, right? And we talk about this a lot. And the question is, why have wages been flat? One of the primary reasons is because healthcare costs have been going up. So compensation has been rising from an employer point of view. It's just that employers are putting more money into healthcare, and therefore wages have been flat for people. The other place where you see a real huge spillover is for state spending on education. So there's been some really nice work. Actually, Peter Orszag, who was the director of the Office of Management and Budget until recently at the White House, when he was an economist, did some really nice work, and other people have done nice work showing that every time Medicaid spending goes up for states, states cut back almost dollar for dollar on higher education spending. And so if you think about what's going to happen over the next 8-9 years in terms of state spending on Medicaid and other sort of state-level healthcare stuff, it's going to have big impacts on how much states spend on everything else from a social policy point of view. So there are real costs to a healthcare system that spends $4.6 trillion. Questions or thoughts about that? I mean, again, I don't think any of this is surprising. You guys know this. But it's worth keeping in mind that that's the policy context in which we're thinking about HIT.
So I guess
yes?
the question is there a plateau or is it a never rising phenomenon in healthcare costs that are going to blow everything apart?
Right.
But
So the question was, is there a plateau or does this keep going forever? Well, there's always the 100% of GDP as the upper limit. But no, in all seriousness, if you look at the projections, they don't seem to have a natural plateau at some point. You know, projections beyond 10, 15 years get really dicey because you don't know what's going to happen. But if you think about what's going to happen, when you do get into those projections beyond 10, 15, 20 years, I mean, it just ends up gobbling up the entire federal budget, right? So we will have no money to spend on anything else. And it's going to have same kind of destructive effects on states. And you know, as a healthcare person, I'm a fan of spending on healthcare, but there is a point where the cost to everything else in society becomes pretty substantial. And my sense is we're going to hit that in the next 5 to 10 years.
Well, I mean, I think what we've seen in the debate about healthcare reform is that, you know, you have the haves and the have-nots, and the haves don't want to give up anything, and the have-nots don't know how to advocate for what they need, and so it just implodes, you know,
Right.
and it's no one seems to be able to take this issue on to say it's unsustainable.
Right, right, because if it's unsustainable, somebody's going to have to give up something.
Yeah.
And that's a challenge. And I mean, I'm happy to have a broader conversation about the healthcare, but what it does say is that we've got figuring out some solution, some sort of mechanism for dealing with healthcare costs is, in my personal opinion, and lots of people's opinion, the single most important domestic policy issue we have. Not the most important healthcare issue, the most important domestic policy issue that exists. Kevin.
Yeah, the haves are mostly people with Medicare, and the haves are a fiction because Medicare's out of money in that 5-year period. So, you know, the issue is this is not sustainable. There's for $6 trillion, you know, for $2.5 trillion of cost, there has to be $2.5 trillion of payments, and there's nowhere where you can identify how that is sustainable on the public or private sector going out. So this isn't. I think this is no longer. We've had these talks about. Stu Altman talks about the percentage GDP going up for forever. Our conversation now is how isn't the costs are important. There is no longer the money coming into this, and it's hard to understand where that would. I mean, just health reform alone was $500 billion out of healthcare. So the issue is, if you don't look at where the revenue is coming from, you're not going to see this huge cliff of the absence of revenue coming into the system.
Yeah. Okay, so I think we all agree there is an urgent need to deal with costs as one part of the broader issue. And the flip side of this is, of course, the fact that there's plenty of evidence that the care that we deliver, now I'm not making comparisons to other health systems, but what I am saying is that if we're going to spend $2.5 trillion, we ought to have a healthcare system, I think, that's performing much, much better than what it is doing today, right? And we have lots of data from every study, including lots of stuff that has been done out of here and other places, that show that we fail to provide effective care to people in a timely fashion. Care is often unsafe. It's not often patient-centered. And I don't want to spend a lot of time on this, but again, it's just to say $2.5 trillion would be one thing if the healthcare system was performing perfectly, but it performs far less than perfectly. And that's sort of part of the context in which we, I think, have to think about HIT issues. Oops, I'm going backwards. All right, I'm going to actually skip this. So, so what does this have to do with HIT? If the fundamental issue is cost and quality, what does this have to do with HIT? Well, what's been interesting in the policy world has been a pretty broad bipartisan agreement that health ITs, or the lack thereof, or paper-based records are really fundamentally part of what's broken in the healthcare system. And if you think about it from a clinical point of view, it makes some amount of sense, right? When you practice medicine in a paper-based world, you don't have information that you need when you need it. And that leads to, as I sort of write up here, inability to access key data at the point of care, lots of errors, lots of repetition, lots of practice of defensive medicine, and I don't mean that from a malpractice perspective, but the fact is you're seeing a patient, you've never seen him or her before, and you have no idea what's been done for them. And so the right thing is do everything, repeat everything, and see what data come in. And it's entirely possible that that person got that exact same $1 million workup a week ago at another hospital down the street, but you have no access to any of that information. And so there's pretty broad consensus that, that you can't really run a complex $2.5 trillion healthcare system based on paper. It just is not a good way to do it. And it's actually contributing to a lot of the quality and cost problems that we have. Questions or thoughts on that before I move on? Okay. All right. So if you look at the evidence base on health IT, and there's probably over 400 studies that show that if you put in electronic health records, you can improve quality and potentially reduce costs. And this is, I think, part of what has really captured the attention of policymakers. Because if you look at these studies, what you get is you can have improvements in terms of adherence to clinical guidelines. You get reductions in medication errors. There are some studies that suggest that if we actually put in electronic health records throughout the country, we could save $100 billion a year. And even in the healthcare system, $100 billion a year is real money, right? And that has really, as I said, it has captured the attention of policy folks and has led to pretty much broad bipartisan support. I remember back in 2006 watching a news conference in which you had Senator Hillary Clinton, at the time Senator Clinton, and Newt Gingrich standing next to each other doing a joint press conference about the importance of electronic health records. And I thought, wow, we've made it. Once you get Hillary and Newt on the same page about something, it's either terrific or scary, and it's probably a bit of both. Because you never get that kind of bipartisan consensus on anything. And yet here it was, here's the topic that seems to have gotten everybody on board, that this is going to be a big part of the fix for the healthcare system. I'm going to figure out how to move forward. All right, so now I want to actually spend a couple of minutes talking about some data for some of the stuff that we've been involved in over the last couple of years. So in 2005, President Bush at the time said he wanted 90% of Americans to get their care through an electronic health record. He initially said in 2009, later got revamped to 2014. But when he said 90% of Americans ought to get their care through an electronic health record, the people in the policy world, the first question they said was, all right, it's 2005, where are we now? If we're at 80%, that sets up a different set of policies to get you to 90. If we're at 5%, you need totally different set of activities, right? And then the other part was, what the heck do you mean by an electronic health record? Because the idea was if you got 5 experts in the room and asked them to define an electronic health record, you'd come up with 6 different definitions. And that was part of the issue. So we started doing some work to try to just understand what the literature was, what the definitions were that people were using. And what we found was that there have been dozens and dozens of surveys of electronic health record use in the US, and most of them were lousy. So either they used non-random samples. My favorite was, there was a survey of CIOs at a HIMSS meeting. HIMSS, by the way, is sort of the trade group for the vendors. And it was a convenience sample of CIOs attending a HIMSS meeting with the question, do you have an electronic health record? And 57% of them said, yep, we have an electronic health record. And people said, oh, 57% of hospitals in America have an electronic health record. Right? Bad survey design leads to potentially really bad policies. There were other surveys of hospitals that suggested that 5% have an electronic health record. All right. So if you think about it from a policymaker point of view, if someone comes to you and says somewhere between 5 and 57% of American hospitals have an electronic health record, you say that is a completely useless piece of information, right? Because I don't know what to do with that. It's too broad a range. And so a lot of the work that we started doing in this area was to try to get clear definitions, good data, national samples. And I think it fed into what came out of the stimulus bill, and I'll show you that in a second. So I kind of hinted at this. So the first thing to do when you're going to do a survey of electronic health records is to not ask people whether they have an electronic health record. Because, again, that's not an interpretable question. People have their own ideas of what that means. And so our surveys focused on functions. We said, do you use an electronic system to prescribe medications? Do you use an electronic system to record notes? And asked about a whole series of functions, and then got an expert panel together, because we didn't know how else to do it, to define what might be a basic electronic health record and a comprehensive electronic health record. But the idea was, if you didn't like our expert panel definition, you didn't have to use it. You actually had underlying functionality data, and you could create your own definition. But it was to try to, again, look at national samples and focus on high response rates and use clear definitions. And I'm going to now talk about, we did a survey for physicians, we did a survey for hospitals, and I just want to spend a couple minutes showing you that data to talk about what led then to the stimulus bill that came out. So here was the idea from the expert panel. And if you don't like this definition, as I said, you can blame the expert panel. I'll give you a list of all the people on it. But they said, again, the idea was let's create the notion of a basic electronic health record was what a practicing clinician might need to really change the way they deliver healthcare. So you had clinical notes, problem lists, medication lists, electronic prescribing, results management. And then comprehensive was 17 functions. And I'm sorry to get into some of the details, but I want to give you a little more of a kind of granular feel for what these definitions mean. It adds in a lot more documentation stuff. It looks at decision support. You're looking at lab results, but you're also looking at radiology images. The comprehensive record is sort of the vision for what a paperless office is. And policy people were really interested in how many people can meet that definition. Okay? And I'm going to show you what these data showed. And we actually then went back and we were able to piece together some of the data from the National Ambulatory Medical Care Survey, which has adopted our survey, to try to see how these things have been changing over time. But let me give you just a feel for where the country is in 2009. So if you can you guys see this in the back? Yes, more or less? I see a few heads nodding. All right. Oops, I don't know if this is, got it. But basically, in 2009, that's the latest set of data we have, about 6% of doctors in America have a comprehensive electronic health record, and about 20% have a basic electronic health record. And that means that about 70-some-odd% of doctors don't meet either of those two definitions. And when we first did this in 2008, the numbers were closer to about 20% combined between basic and comprehensive electronic health record. This is almost completely driven by what your practice size is. So if you look at large practices with 50 or more physicians, 2/3 of them have a basic or a comprehensive electronic record. If you look at physicians in 1 to 3 physician practices, the combined basic and comprehensive adds up to about 5%. By the way, what percentage of doctors in America practice in 1 to 3 physician practices? 10%. So I hear 10%. Half? Anything? Anybody else? So it's about half. It's about 60% of doctors in America practice in 1 to 3 physician practices. So that's a pretty striking number, right? That means that most of our experiences of working in physician practice groups that have 20, 30, 50, or 100 docs is completely atypical for how Americans get their health care. Most Americans, not most, but a majority of Americans are going to practices where there are far fewer physicians, usually 2, 3, 4 at the most. And most of those guys don't have an electronic health record. And if you think about how hard it is to get electronic health records into their offices, it's a whole different set of challenges than doing it for the cardiology practice at Duke, right? Which has lots of docs, lots of resources, lots of infrastructure, can do it in a very, very different way. These numbers surprising to people? Did the people know this already? At least a few people didn't, so that's exciting, imparting some knowledge. Questions or thoughts on this? For those of you who didn't know this, is this surprising? Come on, I was told this was not a shy group.
I like the way you presented it between basic and comprehensive, because I've seen overall statistics, but nobody sort of broke it down
Okay.
into the different components, so I think that's good.
So
One thing you could comment on is the rate of growth. It's actually not exactly impressive if there is this horizon coming down.
all right, so I'm just quickly repeat those two questions. One is, Rowena was saying that she likes the sort of notion of breaking it down between comprehensive and basic electronic health records. And Adrian asked if I could comment on the growth here. Right, so the growth, if you look at this, is over, in 06 we were at about 13.5%, gone up to about 27. So it's been going up at about 4 or 5% a year. And the question is this a linear growth? Is this at some tipping point where it's going to now take off? And the answer is I don't know. And the policy people have been pretty convinced that we're at a tipping point where it's going to just explode and we're going to get huge increases over the next 2-3 years. They may be right because there's a bunch of incentives, and I'll show you the data in a second, that are coming that are going to help with that. But you're certainly right that in this time period, the growth rate has not been, growing like gangbusters. Yes?
There a particular sector that this is growing most rapidly, for example, health maintenance organizations or
Right, so the question was, are there certain sectors of the healthcare economy where you see real growth in electronic health record use? So as I sort of alluded to, large practices is where you've seen this. So whether it's large practices in a managed care organization setting, or it's large practices in a fee-for-service area, a fee-for-service environment, it's been the multi-physician, multi-specialty practices where you see real growth. And again, physicians who work in 50 or more physician practices, these numbers have really exploded and are now well over 50% of those practices have them. Yes?
I was wondering whether
You-
Thanks. I was wondering whether the ability to communicate between records was part of your definition of comprehensive, because it seems like that would be an important piece in terms of of maximally utilizing the technology.
So the answer is it was not, though I completely agree with you that that's critical if you're going to get any of the real quality and cost gains. The ability to share the data across providers is huge. Now, obviously, within your practice, these things, you can share the data, but that's a different notion than I think what you're getting at, which is if you're a four-physician practice and your patient goes off to the hospital, can the hospital look up your record and look up the patient's record? That was not part of this definition. Yep.
So is from the data that's available with large practices that have recently moved to electronic medical records and the efficiencies within that practice, cost savings and so forth, is there good data that way that can be held up as an example to the smaller ones, presumably that may have more limited capital get into this initially? And you alluded to incentives maybe making that, but seems like if there's a good model that shows that it works, that would be promising for a more rapid increase.
It's a great question, and I'm trying to decide whether to punt on it for about, can I punt on it for like 5-10 minutes?
Sure.
But if I don't address it, please make sure that I do in about 10 minutes, okay? Okay, so I'm going to actually now show you the hospital side of things. Maybe I'm going to show you. All right. So we did a similar approach to hospitals, and here we surveyed all the acute care hospitals in the US, worked with the American Hospital Association, and took a very similar approach in terms of, I told you already, the prior data suggested adoption rates were between 5 and 57%. So the EHR definition that, because hospitals are more complicated than practices, right? Practices, you have your location. In a hospital, you can have some stuff in one place, but not in the other. And so the expert panel definition, again, I don't want to spend too much time on the definition here, but was 10 key functions, but let me tell you the hardest ones were computerized prescribing and clinical notes in at least one major clinical unit of the hospital. That and then a bunch of stuff around results viewing and patient demographics as a basic, and then comprehensive was 24 functions, including all the decision support in all the major units of the hospital. So pretty different bars. The idea was comprehensive was sort of a high bar, kind of like the paperless hospital notion. And then a basic was a much simpler thing that we said, if you can at least do this, you should be able to get some value out of it. And here are the numbers for hospitals. Now, here is my classic example of cheating by taking the scale and making it from 0 to 10%. Right? I could have done this scale from 0 to 100. Excel lets you do it very, very easily, and these numbers would have looked particularly unimpressive. But by making it from 0 to 10%, it looks like, hey, there's real movement happening here. But between 2008 and 2009, we saw that the rate of comprehensive electronic health records almost doubled in the country, from 1.5% to 2.7%. And the basic electronic health record also improved about 1.6%. So the bottom line, as I see the hospital EHR data, is about 90% of hospitals don't meet even a basic electronic health record definition. So even if you had those 10 functions in just your emergency room, you would have met the definition. Didn't have it. And the number is growing very, very slowly. Okay, questions or thoughts on this? All right, so what's the policy response to this? And I want to spend just a couple of minutes talking about high tech, as the actual act is called. It comes from the stimulus bill of 2009. How many people are pretty familiar or have heard about the notion of meaningful use, financial incentives for electronic health records? That's about a third of the people in the room. Okay, good. So it means, so let me kind of walk you through what is in the bill. So in the stimulus bill of 2009, you know, the Recovery and Reinvestment Act, Congress put in about $30 billion for health IT, okay? About 28 of that goes in direct incentives for providers, about $44,000 per physician, and depending on the size of the hospital and your patient mix, between $2 and $10 million for every hospital if they meet meaningful use. The financial incentives begin now. So fiscal year 2011, by the way, started October 1, 2010, for those of you who follow the federal government fiscal years. And they've released the final rules for what you need to do to be able to meet meaningful use in July, so a couple of months ago. And the incentives are front-loaded. So if you can meet the meaningful use criteria in 2011 or 2012, you get bulk of the incentives. If you don't, you actually get far fewer incentives. And if you don't meet meaningful use by 2015, there are actually penalties. So carrot followed by the stick. And the stick is you're going to get reductions in your Medicare payments if you don't meet meaningful use by 2015. So it's a pretty significant piece of legislation that I think really has the potential for having a big impact on the healthcare marketplace in terms of, it's, at least for physicians, it's real money. You know, $44,000 is real money. For hospitals, depending on your size, $2 to $10 million may or may not be substantial amounts of money. By the way, if you're a hospital, how much does it cost to put in an electronic health record? I realize it's a vague question, probably depends on the size of the hospital. But let's say you're a 200-bed hospital, you know, medium-sized hospital that doesn't have computerized prescribing, doesn't have electronic notes. How much do you think you might spend to put in an electronic health record?
More than $2 million.
All of it. From the day one of trying to pick a vendor to the final day when everybody's using this stuff in your hospital.
Includes training and all.
Includes training. I'm just trying to come up with a number. What do you guys think? What's that?
$1 million a bed.
$1 million a bed. 200 million? I hope it's not quite that expensive. It could be. It's not crazy. I mean, the number you're throwing out is not a crazy number. It's a little higher than I would have thought for a 200-bed hospital. But it's not that much. So any other guesses or thoughts? Right, so it depends a lot on how much money you put in for training, depends on how much customization, blah, blah, blah. But a number that you might think about, I would have put it, just having heard lots of hospitals tell me how much they've spent, probably in the order of about $50 to $60 million over a 3 to 4 year project. So your 200 is a little higher than what I would have guessed, but it's not an order of magnitude off, right?
How much of that is actually purchasing the software itself versus?
So again, I'm making up numbers, but in the $50 million, I would say the software and hardware costs are probably, just purchasing the system is probably $5 million. A large chunk is all the interfaces Because you'd sure love it if your lab system worked with the EHR, and your pharmacy system, and your radiology system, and your billing system, and your admissions and transfer and discharge system, and I can keep going, right? You want all that stuff to integrate with your EHR for it to be useful. That's probably the single biggest expense. And then you want all your doctors and nurses to be able to use the system. And so you want them to get trained in it. And if you're going to not make your entire staff miserable, you actually want to pay them for the hours they're going to spend training. And that gets really expensive. And all of a sudden, you can imagine how a $5 million purchase becomes a $50 million expense.
Hey, so Ashish, why should hospitals waste their time or effort to try to meet 2012 goals? I mean, we've heard here at Duke actually reports of $100 to $300 million to try to improve the electronic health record system for HIT.
Right.
And $2 to $10 million doesn't seem to cut it.
Right. And for a bigger place like Duke, it might be more like $10 million, but that's still $10 million over 4 years is not going to be the deciding factor, right? By the way, Kaiser Permanente just finished their implementation of their electronic health record. Anyone know how much Kaiser spent? They have about 35 hospitals. They take care of about 7 million people. 4 billion. Yeah, $4.1 billion. I don't know how much they're going to get in financial incentives, but it ain't going to be $4 billion, right? So I think the incentives, at least on the hospital side, now on the doctor side, the numbers that are thrown around in terms of how much it costs for an average physician is probably about $50,000 to $60,000 between training and all that other stuff per doc. So in that context, the incentives are real. I mean, they actually cover a good chunk of the costs. On the hospital side, it's a pretty tiny number for most hospitals. And it's not clear, to answer your question, Adrian, it's not clear that this is going to be the thing that's going to drive adoption. Couple of things, though. One is a lot of hospitals are already thinking about doing this, and the money becomes kind of the thing that tips you over. So I do think it's going to have some impact in terms of accelerating adoption. The penalties that kick in 2015, there's a lot of skepticism in the marketplace about whether those penalties will ever kick in, right? Congress is not great about penalizing doctors and hospitals who take Medicare money for all the obvious reasons. So they have consistently, if you look at the debate around the sustainable growth rate, cuts of payments for doctors, every time Congress gets close to cutting payments to doctors for Medicare, they back off. And so there are a lot of people who are saying they're going to back off on this as well, but the legislation right now says that those penalties kick in automatically. And whether Congress will do a fix, I don't know. So there is this idea that at some point with the penalties, and then there's the last part of this, which is, so we're in the year 2010, right? When you think about, so for instance, for this visit of mine that I'm here for, Adrian emailed me. We set up all of this stuff electronically. All the meetings I've had, this discussion. I emailed this talk to Charles to say, we didn't do this by him writing me a handwritten letter, faxing it to me, hey, do you want to come visit Duke? I mean, the point is, like in most of our lives, we do all this stuff electronically. Except when you walk into the healthcare system, and then people are writing stuff by hand, and they're faxing things. Even hospitals that are right next to each other are printing out their electronic records and faxing them over to other hospitals. There's sort of this disconnect that says, we got to move forward on this. You can't have a paper-based system forever. Yes?
Just curious as to how much of the
Having dealt with some of these records, is due to the inadequate software products that are currently available. Some of these things are incredibly painful. I hear rumors that other centers have great systems. It's like the grass is greener somewhere else.
Right.
But the ones that I've seen really are underwhelming, and it reminds me of using computers back in the days of the 386 processor and the DOS operating system. It's just like, okay, we're starting somewhere, but this is, wake me up, when we get to the iPad era.
Right. No, it's a great question. I mean, there are a couple of related issues on that. So one is there are probably about 200 electronic health record vendors out there, right? And the quality of those products are incredibly variable. And I haven't heard of anybody who feels like their electronic health record system is awesome. So there is this notion of, and I bring that up in conjunction with your comment to say, this is, in some ways, we're early in the marketplace. The consolidation hasn't happened. You haven't seen the breakout products. And a lot of people have pushed back to the federal policy efforts and said, is this really the right time to push everybody onto this? Shouldn't we wait 5 years until we have better products, a more consolidated marketplace to do this? And the push back on that is $2.5 trillion. We're going to add another 30 some odd million people in 2014. Can't run the healthcare system based on a paper-based record. It's already kind of not functioning and not working as it needs to, and we need to move. And that tension exists, and that tension is what people have been trying to grapple with. Can't wait, must wait. How do we do this? Kevin?
Yeah. So have you looked at why this is the case? So you're talking about basic failure of business models. Okay, so this technology, the way it was deployed, didn't provide value. Otherwise, hospitals would have bought this. We didn't need, I didn't need the hospital to tell me to get an email system, right?
Right.
So there's a basic failure there. And in understanding where that basic failure is, you get to the question of where's the value to health IT, which you haven't really talked about yet.
I'm going to go there next. Yep.
Okay, because I think the answer is in looking at those questions. And you won't get an answer to Dan. You won't get a technology that's viable until there's a real business model behind it.
Right.
And we haven't gotten there.
So in some of the stuff we did when we surveyed physicians and hospitals, we asked them a bunch of questions about why have you not adopted electronic health records, right? And the number 1, 2, and 3 answers were money, money, and money. They answered it in slightly different ways, but it came down to that. And the notion is pretty straightforward, which is they have to put up the money to buy this stuff. And if there are cost savings at all, they don't get to realize any of it. So for the physician who says, great, I now order fewer lab tests, or I don't have to order as many radiology tests, that's terrific, but I wasn't paying for that anyway. So I get to pay the cost, but get none of the financial benefits. And that's sort of the notion of why you see places like the VA and Kaiser move forward on this, because they get to internalize the financial benefits if they exist, in a way that the fee-for-service world does not reward. So I think that's part of the answer to your question. Was there another hand back there? Yeah.
Just in speaking to that communication question that you put forward, I mean, a lot of it, up front when you're developing these EHRs is to, companies are developing, they've got a competitive edge, something that makes them unique compared to others.
Yeah.
But an inherent problem to that is how do you communicate the basics? So for example, I've got a regional hospital that's got an EHR of its own.
Yeah.
I've got another regional hospital that's got an EHR, and the two EHRs just don't talk to each other. So to a certain extent, you kind of need a template for development. The American College of Cardiology, for example, has developed a fabulous registry that's supposed to look at outpatient care of acute coronary syndrome, for example.
Yep.
And their goal is to say, well, for practices that already have an electronic health record, I don't need you to fill out another case report form. We're just going to take some very, very basic things, age, gender, problem list, things that really should be common to all of these EHRs,
Yep.
records, and funnel them into a collective database. And it's 2 years later, and they're still trying to figure out how to do that.
Yeah. Well, that's a great example, because I was going to say, as you were talking, I was going to say, how's that going? I don't mean that in a cynical way, but if you look at the way, so let's take something like gender. There are literally dozens of different ways in which different EHRs code gender, right? Some of them do it as MF, some of them do it as 10, 12, men, women. Lots of them have more than 2 categories. And the problem becomes, if we can't abstract the term gender from an electronic health record in a systematic way, what hope is there for diagnoses? What hope is there for severity? Forget all of that. So the lack of standardization has been a major problem in terms of getting data to flow from one system to another. And it's actually, in some ways, I hate to be negative about this, but it's even worse than that because so the same vendor, their electronic record systems that are like two different versions can't talk to each other because vendors are changing these things all the time. So one of the things that the federal government has been doing in the last couple of years, and I think with some success, has been trying to get some amount of standardization. So for instance, now going forward, certified electronic health records will use the same approach to capturing gender and age and race ethnicity. And they'll use SNOMED for codes, for diagnoses, and they're going to use LOINC for labs so that my sodium and your sodium computer systems can recognize we're talking about sodium levels, right? That's huge progress. It's taken 5 years, and EHR vendors are going to now make products that are consistent with that going forward. And so it'll make the AHA or the ACC effort that you're describing a lot easier. But it took 5 years to get to a point where we can talk about gender in the same way. And that's part of the challenge here. Now, what's interesting is in other industries, this turns not to be as much of a problem. I was talking about this last night with Adrian and a bunch of other folks, is you usually get standard setting by big players in the field. So the retail industry, people often talk about Walmart as the 800-pound gorilla in the retail industry. They say, you can talk about, if you want to talk about soap, you can talk about soap any way you want as long as you talk about it that's compatible with our system. If not, you don't have to sell soap to us. And guess what? Most manufacturers are not interested in leaving Walmart out of their potential supply chain. And so what they will do is they all change their systems to be compatible with the Walmart system, and then therefore they end up being compatible with each other. And you've had this sort of 800-pound gorilla effect in lots of industries. There is nobody who can do that in healthcare except Medicare. And there's no way Medicare has been very kind of careful to go down this road because they don't want to overplay their hand, and they've got some political considerations in a way that Walmart doesn't, right? If Walmart upsets Procter & Gamble, they're okay. If CMS upsets some big hospital chain, that big hospital chain is in some congressional district, and that congressperson is going to come to CMS and say, why are you upsetting my hospital chain? So that's the challenge that public entities have to deal with. Oops. Sorry, I'm not doing a very good job of this. Okay, let me just show you one quick thing. So we recently just did this analysis, published this about a month ago, to look at some meaningful use. The brand new meaningful use criteria just came out. What we try to figure out is how many hospitals are going to be able to meet meaningful use as of 2009. And based on the data we had from the hospital survey, I just want to show you the bottom line number. Depending on which definition of meaningful use you use, our estimation is that in 2009, between 1.5% and 2% of hospitals are going to be able to get the meaningful use incentives. This is very problematic because obviously you don't want to have an incentive system that rewards 2% of hospitals. And this is data based on 2009. Remember, meaningful use rules are kicking in now. So a lot of hospitals are going to have to move very, very quickly to get to meaningful use by 2011. All right. I'm going to actually move on. Okay, so I just spent 2 minutes talking about what this looks like compared to the rest of the world. Because one of the things that policy people have often talked about, can you guys see this okay back there? Great. Is people spend a lot of time saying, oh, it's just, we're a mess, but the rest of the world has got this figured out. And the answer is it's a little bit of a mixed story. So let me kind of walk you through what's here. So if you look at the data, on the ambulatory side, right, ambulatory care, we aren't doing great, right? Here we are. This is actually from 2000. What I try to do was go through data from other countries and kind of standardize it to about 2008. What did we know? And here we are, about 17% of doctors in 2008 were using the electronic health record. About 30% were prescribing electronically. And if you look, Canada's actually further behind than us. You have a nice national single-payer system. People were convinced that's going to be your solution. Turns out not so much for Canada, which is 1/10 the size of the US. But then if you look at a bunch of other countries, and I could have put a whole long list of other countries on this list, England, Netherlands, Australia, Sweden, they're much, much further along in terms of ambulatory electronic health record adoption, right? So on the ambulatory side, there are a bunch of other countries that have clearly made huge progress. And by the way, they've been at it for a long time. So most of these countries have been working on this for about 10 to 20 years. When you switch to the hospital side, the story is not so simple. And so here are our numbers, right? Computerized ordering, about 30% of hospitals have some of it, about 12. In Canada, again, behind us, but all these other countries, except for Sweden, so I'm going to actually ignore Sweden for a second. Sweden is just atypical. But if you look around the world, nobody else seems to have made much progress on the hospital side in terms of electronic records. And it's primarily CPOE that's slowing people down. Almost nobody, again, there are a couple of exceptions. Sweden is an exception. Hong Kong and Singapore both have very good adoption of electronic health records in their hospitals, but Hong Kong and Singapore are tiny city-states, not 300 million people in a large, complex nation like ours. And so on the hospital side, pretty much everybody has struggled in terms of electronic health records. And what's been important about some of the work we've done around these international comparisons is it's broken this, what I think is a very simplistic notion that US policymakers have had that we're horribly behind because we have a fragmented healthcare system and yet everybody else has figured it out. There are some real challenges, even in single-payer systems like England and Canada, where electronic records have been slow to move forward. Questions or thoughts? Yes?
How do these other countries solve the vendor issue, or how have they?
So I have a partial answer to that. But I don't, so the partial answer to that is they haven't had the same vendor problem in the sense that most of these countries have had 4 to 5 vendors to deal with. Sweden had 3. England has had, in the ambulatory side, 5 main vendors. We have 200. So that's one thing. It's much easier to get 5 people around the room. There are 2 things that I'm not answering when I answer that. One is, why do they only have 5? How did they get there? I don't know. That part's not so clear. But the other part that I think is worth noting is that in these countries, clinical data exchange is not happening. So just because they have widespread use of electronic records in the ambulatory side, it doesn't mean doctors can communicate with hospitals and hospitals can communicate with other hospitals. That's not happening almost anywhere, with a couple of really tiny exceptions. One, for instance, is Scotland. Scotland, 5 million people. They've got a clinical data exchange program that's kind of working, but is pretty limited, where they can exchange labs and medication lists, but that's it. So clinical data exchange is not happening anywhere in the world in a systematic way. So there are some challenges that even these countries have not been able to solve. Okay, other questions or thoughts on the international stuff? I'm going to actually skip through some of this stuff. I want to spend a couple of minutes talking about just one more set of data. So and in some ways, this is a hard one to end with because it's in some ways a little bit more depressing yet. But so I started off by telling you that there were about 400 studies that suggested that EHRs could improve quality and reduce costs, right? And again, I started this whole talk by saying that's what we care about. I love technology. I'm a technology geek, but the goal here is not technology. It's better care at lower costs. And I could point to those 400 studies and say, look, at the Brigham or at Vanderbilt or at Indianapolis, they put in this electronic record system and had this nice impact on quality. That's great. So, but most of the data, as I say here, are from high-performing systems, and there is a sense that these data may not be nationally representative. And so some of the work we've done is try to look at, now that we're getting some amount of traction in the community, 10 to 20% of doctors and hospitals are adopting this, do we see that these hospitals, for instance, and I'm going to show you hospital data, actually have better quality and lower costs when they have electronic health records? And what I'm going to show you is data from one study that we published about 6 months ago. The study was fundamentally flawed, and it only made sense if the answer came out in one direction. And we took our chances and studied and did it. But let me kind of tell you the flaw of the study. It was a cross-sectional analysis looking at EHR adoption and quality and cost metrics. And it's flawed because you're going to tell me not a randomized trial, it's horribly biased. People who adopt EHR, especially when you're at 10 or 12%, are not a random sample of anything, and you're biased towards finding an effect, right? High quality hospitals should have EHR, should have better quality and better outcomes and lower costs, and it's not going to tell you that the EHR had anything to do with it. And with that as a bias, as we were doing this analysis, we thought it's still important to do because it hasn't been done in a nationally representative sample. And I was thinking a lot about how was I going to write the discussion section and how badly were we going to get beaten up by the reviewers, and could we do something to try to make a convincing argument that it was really EHRs that were helping hospitals. Okay. So here's our first set of data on looking at EHR adoption and 30-day mortality rate from the national sample. So this is acute MI, heart failure, and pneumonia. In the blue bar are the hospitals with a comprehensive electronic health record. The ones in the red bar are the basic electronic health records, and the orange is the no electronic health records. Okay, so again, remember where the bias of the study is, and what we found was pretty much a null finding. Would you guys agree? I have, by the way, shown this to, I don't know why this bar is a little higher, it should be a little lower. I have shown this data to EHR enthusiasts who are convinced that this is great evidence that EHRs actually improve mortality because comprehensive records are a little bit lower than every other group in each of the three analyses. And I think you have to be pretty sold on this stuff to buy that that is convincing evidence that EHRs are making a difference, right? So personally, I was surprised when we saw this, the first set of output came from the programmer. We were expecting that we'd see better outcomes, and then we'd be scratching our heads trying to think about how to interpret it.
The ends for each of the groups.
Oops, let's go back. What are the ends? Yeah, so part of it is, right, our power got some power issues. This was a survey where we had about 2,500 survey respondents, and so the comprehensive one is about 2% of that. So it's only about 50 hospitals here. In the basic, it's probably about 400 hospitals, and in the no EHR, it's about 2,100 hospitals. So it's not super well powered, but if there was a 0.5% mortality difference, we would see it between the basic and no EHR. So it's not, but it's also not 50 hospitals total. It's 2,500 hospitals in the total sample. Yes, sir.
Why did you think that there would be a difference in mortality?
Because I study EHRs, I wanted to make sure that it has here's the reason.
How would it work if there
So
were?
what's the mechanism?
Yeah, what would be a mechanism that would make this hypothesis plausible based on what we know?
We looked at a bunch of other outcomes too, but we looked at processes and the results were broadly similar. The issue is this. So we know EHRs reduce medication errors and adverse drug events. We know that they do help and can help improve adherence to guidelines. The 400 studies have all shown, not all shown, but a lot of them have shown that you do a lot more evidence-based stuff. And so the notion here is if you follow guidelines, you provide better care, you have fewer errors, you might be able to pick it up in a bottom line number like outcomes. The other part of this is you could argue that this really is the metric or one of the metrics we're going to care about. And so if you're not seeing the impact on mortality at all, we also looked at 30-day readmission rates, sort of a similar thing. If you're not seeing it in the metrics that you think are really important, it tells you something about how much of an impact these systems actually have. You're not buying it for half a second.
No, well, what this suggests to me is that the EHR is kind of the heated nuts in the airplane ride of medical care. It's nice to have,
Got it.
but in a lot of cases, it's not mission critical to arriving at your destination.
I didn't
Because
understand
we've
the
got
impact
100
first. I
years
get
of
that.
practicing the other way. I
Right.
mean, we're not that bad most of the time.
Right.
16% of the people who came in.
But they were going to die anyhow.
Of course. In fact, I think what you're saying is right. I think there are two potentially important points to be made out of this, though, right? One is, so one of the things I've been worried about in the policy debate, again, going back to the Newt and Hillary standing next to each other, Newt Gingrich's favorite line about electronic health records is he says, "Paper kills." And paper-based records are killing hundreds of thousands of Americans every year, and we've got to switch. What's that? Certainly hundreds of thousands of trees, but policy people have been making the argument that it's also killing hundreds of thousands of patients. And this helps you get a little bit more of a realistic picture of what these systems can do. I actually agree with you fundamentally that I would say more than it's nice to have. I would say it's a necessary but not sufficient part of transforming the healthcare system. You can't get to high-performance medicine and high-performance healthcare in a paper-based world, but just putting in an electronic record ain't going to get you there. It's that part of a broader set of stuff. It is 1 o'clock, so let me just kind of show you some other. We looked at a bunch of cost measures. The previous slide I went through was risk-adjusted length of stay. This is risk-adjusted costs, and basically showing that, again, just not a lot going on. Hospitals that have adopted these systems don't seem to have lower costs. They don't seem to have better outcomes. They don't seem to have much in the way of better processes of care. So what do I want to finish with? I'm going to just let me actually just finish this. So, what's been interesting in this, watching this policy debate over the last couple of years has been, there has been this several years of what's somebody described as magical thinking about electronic health records. This idea that we just got to get these systems in place and we're going to have this big transformative effect. Now, I would make the point that given where the healthcare system is today, health IT is a pretty central part of any transformation effort, right? So if you think about the other buzzwords of 2010, accountable care organizations, patient-centered medical home, you name the hot topic du jour, electronic health records are a fundamental part of that. And we're not, in my opinion, going to make any progress without it. But the point here is that our adoption, and I didn't show you the health information exchange data, but all the data on electronic health records, all of this stuff says we're very early in the game. And there are lots of challenges ahead for providers. And the fact that there's very little evidence of impact kind of once again, I think, reiterates the importance of broader reform. So if we're really going to improve quality and lower costs, putting in electronic systems isn't going to do it. It's going to have to be part of a broader delivery reform, broader payment reform. It sort of sounds obvious to say, but from the policymaker's point of view, in some ways this, I think, has been a little bit of a shock to people who were convinced that the records themselves were going to have a big transformative effect. When I speak to clinical audiences, you guys are not shocked by this, right? No kidding. Technology itself doesn't transform anything. It's technology tied with incentives and a broader environmental change. But in the policy world, this has, I think, gotten a little bit more traction because again, of this magical thinking that's gone on. It's a couple minutes after 1, so I'm going to stop and see if there are any last-minute questions before we stop. Any other thoughts?
Yeah, since DCRI is very interested in trying to take advantage of electronic records for doing clinical research.
Yeah.
Tracy was highlighting one of the challenges for one of their QA registries or QI registries, and AHA has another one that's trying to take advantage of this, as well as trying to develop infrastructure to develop evidence for not only kind of strategies of care, et cetera, but other clinical trials. Like, do you see HIT fitting into that paradigm at all, or is that so far in the distant future that's hard to see?
Right. No, it's a great question. There's a whole broader question that's underlying it, which is the sort of secondary uses of these data for public health, for research, for other stuff. There are a couple of problems, and I think in the next 5 years, I think, again, we're way overestimating what we're going to be able to do with this. Individual systems might be able to do it, right? So Duke could pull out of its electronic medical record a whole bunch of good data that it could use for research in whichever way it wanted. The idea that we're going to be able to cull data from multiple sources into large databases to do research across a large number of organizations, that's going to be a huge challenge, and I don't see that happening easily over the next 5 years for a couple of reasons. One is the technical of getting data from multiple systems. There's a lot of sociologic issues here still of people being nervous about how these data are aggregated. And I think for competitive reasons. So one of the reasons why health information exchange, sharing of data among providers has really not taken off is because providers realize data and information is powerful. And so they have not been broadly willing to exchange and share those data. So while you might get a few large academic centers who are willing to share data for some research sort of collaboratives, and we've seen this in a few places, I think broad-based use of this stuff for research, for other secondary uses is at least 5 to 10 years off, in my mind.
All right. Well, I want to thank you for a great talk, and thanks for visiting Duke.
Thank you.